Good morning, I'm Evan Shlofmitz from St. Francis Hospital in Roslyn, New York, and today we're going to discuss hypotension in the cath lab. These are my disclosures. This morning you've heard some specific ways to manage coronary complications, but it's important to understand the overall approach to hypotension in the cath lab. Anytime you're encountering hypotension in the cath lab, you want to make sure you have a broad differential diagnosis and that you don't miss any potential cause of the patient's hypotension. When hypotension is critical, decision-making needs to be rapid but systematic, and you need to initiate therapeutic measures quickly but continue to reevaluate as needed whether or not the patient's responding appropriately. It's important before you start treating hypotension that you want to exclude false hypotension measures. You need to ensure that the pressure is accurate, make sure that there's no pressure drift or pressure dampening, ensure that the hypotension reading is not due to obstruction within the catheter, either due to equipment, air, thrombus, or contrast. Ensuring that the pressure reading is accurate is an important step, and it only takes a couple of seconds to ensure that that's the case. The differential is very broad, but it is usually most dependent on what was happening just prior to the patient developing hypotension. Things such as a vasovagal reaction, anaphylactic reaction, contrast, pharmacologic induced, either due to vasoactive drugs or oversedation, particularly in the elderly. Pericardial tamponade is an important consideration. Hypovolemia, which may be related to access site bleeding or a retroperitoneal bleed. There's RV infarction, coronary perforation, which could be related either to the device that was inflated or a distal wire perforation. There's cardiac chamber perforation, myocardial ischemia, which could be due to thrombotic occlusion, air embolus, or no reflow, acute valvular regurgitation, cardiogenic shock, stroke, or potentially an arrhythmia. Working through your differential diagnosis may be simplified if you divide the differential into these three main components. There's hypovolemia, cardiac failure, or peripheral vasodilation. With hypovolemia, bleeding is the primary etiology. It's important to check always the access site and rule out any access-related bleeding. You also want to exclude coronary perforation, both at the source of the lesion and for any distal wire perforation. And then you want to treat the underlying cause. You always want to keep in mind the overall clinical picture. Are there ST changes that are occurring? Is the patient having chest pain, back pain? Keeping in mind the overall clinical picture will help clue you in on what the underlying issue is. With cardiac failure, you want to go back to the basics. Cardiac output is simply the product of heart rate times stroke volume. How much blood is pumped from the ventricle with each beat? In cases of cardiac failure, it's an issue with one of these two components. If there's decreased stroke volume, it may be due to ventricular dysfunction. That's commonly caused by ischemia. Valvular abnormalities can often be caused by a catheter, such as with acute valvular regurgitation. And lastly, pericardial tamponade may be contributing to decreased stroke volume. For arrhythmias, either bradyarrhythmias or tachyarrhythmias may be contributing to decreased cardiac output. Peripheral vasodilation occurs with vasovagal reactions or systemic anaphylactic reactions, most commonly contrast-induced, or medication administration such as nitroglycerin or with verapamil. This algorithm from Dr. Berlakis walks you through a stepwise approach and how to determine what the underlying causes of hypotension in the cath lab. As with any complication that occurs within the cath lab, you want to remain calm, work efficiently and systematically. It's important to call for help early, whether that's another physician, another nurse or tech. It's great to have extra set of hands anytime you're encountering complications. It's critical that you know where all essential equipment is in your lab, especially this time of year. A lot of graduating fellows or new fellows are starting in new cath labs, so you need to know where all equipment, not just that you would use for your procedure, but for potential complications, you need to know exactly where it is and how to use it. You also need to narrow your differential diagnosis rapidly. Make sure you treat underlying causes and continue to reevaluate as needed whether or not you've identified the actual cause of hypotension. And it's important while you're going through this workflow, you need to support the hemodynamics, and that might be pharmacologically or with mechanical circulatory support devices. Thank you very much.